Okay, this is Bill again. Caring for a client undergoing cardiovascular surgery. Most cardiovascular surgeries are revascularizations or extracorporeal circulation. Cardiopulmonary bypass grafts, that's where they mechanically circulate and oxygenate blood outside of the body while beating heart is stopped. Disadvantages: long operative period, anticoagulation, hypotension, risk of stroke, and dysrhythmias. Usually the first attempt at revascularization is not a coronary artery bypass graft, but a percutaneous transluminal coronary angioplasty, a PTCA. This is tried, and if it fails to revascularize the circulation, then they will do a CABG, or if there are too many arteries, blockages in there, then they'll do the more surgical technique. The coronary artery bypass graft indications: client has multiple coronary artery occlusions, like I said, athermos are calcified and non-compressible. Anatomic location of the occlusion interferes with the safe insertion of the coronary artery catheter. A lot of times with the failed PTCA and medication, that's when they go to the coronary artery bypass graft. Especially if it's 70% of the left main, they're going to do the CAB just right away. Coronary artery bypass graft continued. Procedure: bypassing or detouring around the occlusion portion of one or more of the coronary arteries with a relocated blood vessel. Graft vessels, usually they take the saphenous vein, but sometimes that saphenous vein has just as much as clots or blockages in that the heart has. So sometimes they have to use the internal mammary artery, which is a better situation because it is an artery, or the internal thoracic artery. But they can use others. They can go up and use out of the arm. The radial artery has worked in the past, and things like that. So they have done that. But those artery ones, they can usually get about 2 out of those before they have to stop and use veins. Surgical techniques: there's the conventional coronary artery bypass graft. That's what most people are used to having. Procedure: they attach harvested saphenous veins to the aorta or below the occlusion. Types: you can do doubles, triples, quadruples. The most I've seen is 5 bypasses off of one surgical technique. But they're really long surgeries and very skill dependent upon the surgeon. Surgical technique: off-pump coronary artery bypass, OCAB, which is no use of cardiopulmonary bypass machine. Adenosine is used to slow the heart rate, but it is still the instrument. They have what they call the octopus that lifts the heart up out of the chest and stabilizes the area that the graft is going to be attached to. Advantage: it reduces the mortality rate, fewer postoperative complications, decreased postoperative recovery time, less blood used, but heart is still beating, so that has to have a lot of skill from the surgeon. The minimally invasive direct coronary artery bypass procedure is an endoscopic procedure. First time these were done in Tacoma, and not many of the people lived. A couple of them did, and they were very happy because it has minimal scarring. Incision is between the ribs. They might take out a portion of the rib. Limitations: only 1 or 2 vessels can be grafted in this procedure. Otherwise, they have to do a regular one. Port access coronary artery bypass, PACAB. It's called a TCAB. Procedure uses cardiopulmonary bypass machine attached to the femoral artery and vein rather than the great vessels of the heart. So it gives them a little bit more access at the upper chest. Triple lumen vascular catheter inserted via a thoracoscope, video camera, and transesophageal echocardiogram to visualize the operative area. Advantage is shortened operative time, procedure, reduced mortality rate and from complications, and a faster recovery. Of course, they don't have the big incision that they have to deal with, but I would rather go with a regular one. Okay, thanks. Question: a client is recovering from a conventional coronary artery bypass graft, a CABG procedure. The nurse can expect which of the following? A, B, C, D. Okay, think about those. All right, we got them? All right, so it is A. A conventional CABG includes a 12-inch mid-chest incision and duration of hospitalization. It says 7 to 10 days, but it's about 5 to 10 days now. Some people are getting out as quick as 4 days for a minimum number of grafts that they have done. Okay. Valve repairs. Now, the valve repairs, we have talked about those a little bit in the past, but the valve repair surgery method of repair, there's a commissurotomy, opening adhesions of the valve cusps with a thoracotomy, a balloon valvuloplasty. That's where they go in there, they put a balloon up through your groin, they go into that valve and they expand that catheter as big as they can, and it stretches the stenosed valves. Then there's a cardiopulmonary bypass. There's a valvuloplasty, which is also where you can do your valve repair. And then you have an annuloplasty, repairs the fibrous ring that encircles the valve, and that can also be done through your groin. So that works out fairly well. There are 3 basic types. There is the mechanical, and one thing with the mechanical, they last for a long time. They last for up to 20 years. So you can get a 20-year extension out of this. But you have a higher risk for a thrombi or embolus to form. You have to be on blood thinners the rest of your life. So that might slow you down a little bit. The bioprosthetic valve, that one there is it doesn't last as long. It has problems with calcification and that, but you don't have to be on the anticoagulation therapy as long. So then there is the mechanical, or not mechanical, but you can actually have a pig valve put in, which goes to tell you that we are closely related to pigs. So they can take and put a pig valve in, or they have actually came out with 3D printer valves now. So it's improved cosmetic appearance and that, but that's the way it is. So, repair of ventricular aneurysms and heart tumors. Ventricular aneurysms cause infarcted areas of the myocardium, balloons outward and form thrombi, myocardial infarctions. Emergency procedure to suture the weakened area. They cut out that little area and do that. Removal of the heart tumors. Benign or malignant tumors are rare, especially for the heart area, because it's mainly a muscle and that. So they don't have a lot of problems with muscle tumors in this area. Benign tumors extend into the pedicle. Uncomplicated malignant tumors, poor prognosis for those. It just keeps on growing. Repairing of heart trauma. Non-penetrating injury to the chest results in cardiac tamponade. That is where the sac that is around the heart fills with blood for one reason or another, causing a crushing injury, causing bruising and bleeding. Treatment is bed rest, pericardiocentesis, or open thoracotomy if it's that bad enough. What they do is they attach a needle to a syringe, a fairly large needle, and they stick it up underneath your xiphoid process, and it has an attachment on it that has an electrode on it, so that it will actually tell if you go too deep and you start getting electricity out of there from your heart muscle. Then you back off a little bit and you can start pulling back and get the blood out of there. Okay. Penetrating injuries caused by a stab wound, large tear, surgery causes immediate shock from hemorrhage. People that have heart stabbings like that, there, stab wounds, a lot of times they don't survive, but there are a few that will do that. Okay, heart transplants. Now, cause cardiomyopathy, end-stage coronary artery disease, end-stage heart failure, congenital heart cardiac defects. National Organ Transplant Act was in 1984. Some of the first transplants did not make it. Hardly any of them did, but there were a few. So it gave them thinking that this would be a viable option. One of the things is you have a high acuity for rejection. You have to be on rejection meds for the rest of your life, immunosuppressant drugs, cyclosporin, and azthiopurine, Imuron are two of the ones that they have to be on for the rest of your life, and they're fairly expensive drugs. Transplant problems, infections, causes bacterial, viral, fungal infections, and, life-threatening, treated with antibiotics, antivirals, antifungals, high cost. Heart transplant, you're looking at million, maybe even $2 million. And most people's insurance are only going to cover the first million. So that's where you're going to look at and see, where is this something that is viable for this person. Cardiovascular disease, CAD, is a common problem among heart transplant recipients. Do not experience angina because heart's nerves supply is not intact. Rate of survival is 85 to 90%. 1 year after surgery, 10-year survival is about 56%. Longest is about 13 and a half years for survival. So scarcity of donors is one thing that stops us from doing these. 20% of 3,000 people awaiting heart transplants die before donor becomes available. So, question: a client awaiting heart transplant are assigned a status code that corresponds with their medical urgency. The nurse understands that if a client is determined to be status 1B, the client must have the following qualifications. So which one do you think it is, huh? Which one? Think about it. Okay. It is client D. Has a left or right implant ventricular assist device. Okay, we talked about those in one of my other lectures. Then we have the vascular surgical procedures of the periphery. Vascular grafts bypass or replace diseased sections of major systemic vessels, aorta, femoral, popliteal arteries. There's human tissue that they use, cadavers, or they've used the synthetic fibered Dacron or Teflon these days. And I've seen aortic, lower aortic, below the renal arteries be done, and they do quite well. It's a cardiac cath procedure. They go up inside their groins, they go up through the iliac arteries, and they release this and attach the Dacron or Teflon graft to the upper above the aneurysm. They pull it out and down one side, then they go up and attach with the other side and pull it down the other and out the other side. Works quite well. Okay, central or peripheral vascular procedures: embolectomy, thrombectomy, removal of thrombus or embolus, including in major vessels. You can do replacement grafts, endarterectomy. That's real common in the carotid arteries. They'll go up and they'll dig it out, clean it out, close it back up, put a Teflon graft over top of it, and the person does real well. They have a high incidence of stroke from cleaning out those valves, or those arteries, excuse me. Nursing management for a client undergoing a cardiovascular surgery. Hemodynamic monitoring, assess the volume and pressure of the blood in the heart and vascular system, surgically inserted catheter. You must monitor this. A lot of LPNs do not have this capabilities in the hospital. It's mainly an RN's job, but they could have you in there assisting them for this, okay? So you want to know what is normal. A normal CVP, a right atrial pressure, is 2 to 7. Pulmonary artery pressure monitoring assesses the left ventricle function. Pulmonary capillary wedge pressure is about 12 for pressure. Nursing diagnosis: knowledge deficit, anxiety. Nursing diagnosis here: risk for impaired gas exchange, and that. So there's all kinds of nursing diagnosis that you're going to go through and use. Okay. Question, the last one. A client recovering from cardiovascular surgery is at risk for decreased cardiac output related to impaired ventricular contraction. To maintain an adequate cardiac output, nursing interventions include which of the following? A, B, C, or D? So think about it a little bit here. Which one are you going to have? Which one? It is B. Administer prescribed inotropic or antidysrhythmic medication. Inotropic medication increase the force of the heart contraction, and antidysrhythmic medication promote normal conduction, depolarization, and repolarization of the myocardial tissue to ensure that those are all working fine. Okay, we got that taken care of now, all right? You guys, thanks for listening. Be safe, and see you when I can, okay? Thank you.